Hello, and welcome to this presentation by the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled Managing Emergency Department Headache Patients, Life-Threatening Headaches and COVID-19 Implications. My name is Edward Sloan. I'm currently Medical Director of the Physician Assistant Studies Program at Dominican University, and I have been an attending physician in emergency medicine at Carle Foundation Hospital. I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. The content for this lecture comes in large part from the monograph titled Evaluation and Management of Life-Threatening Headaches in the Emergency Department by Dr. Zoda et al. It was published in Emergency Medicine Practice by EB Medicine, February 2019. Please refer to the complete video and audio content for this educational lecture, as well as other individual parts of this lecture via links found at FERNE.org. You may also refer to the initial podcast and the CME option on the EB Medicine website at ebmedicine.net and specifically at the link listed below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. The next important secondary headache diagnosis under consideration for ED patients with headache is meningitis and encephalitis. Remember that meningitis can be both bacterial and viral. For example, the patients with a viral meningitis may just have significant photophobia and phonophobia and just want to be in a dark, quiet room till it resolves. If meningitis or encephalitis is suspected, remember, you must provide ceftriaxone prior to having the patient go for non-contrast CT imaging. Steroid use should only be used once meningitis is confirmed by having a cloudy CSF suggesting a positive LP and bacterial meningitis. Whereas ceftriaxone should be given in all patients even when there's a low likelihood but there is a suspicion of meningitis, steroid use is really to be given only in those settings in which we know that there's a confirmed or likely bacterial meningitis in order to prevent complications. What are the etiologies? Strep pneumonia, group B strep, M and meningitis, H influenza, and Listeria monocytogenes. Those are a lot to say. We also have to consider non-polio enteroviruses, including group B Coxsackie and echovirus. And remember that patients with encephalitis can have altered mental status. They can be normal one day and with viral encephalitis have acute psychosis. What's the treatment for meningitis and encephalitis? In neonates up to 28 days, ampicillin with either cefotaxime or gentamicin and acyclovir if viral meningitis is suspected. In infants, give ampicillin and ceftriaxone. In adults 18 to 49, ceftriaxone and vancomycin. In adults 50 plus, ceftriaxone, vancomycin, and ampicillin, treating Listeria with the ampicillin. If there's a foreign body or the patient is post-procedure, give vancomycin and either cefepime, ceftazidime, or meropenem. And if there's a penicillin allergy, the drugs of choice may include moxifloxacin or vancomycin. But please note, if the penicillin allergy was just a rash as a child, it's probably okay to give the higher generation cephalosporins since there's a low cross-reactivity and allergy from the administration of these drugs. And these higher generation cephalosporins are great for CNS penetration and the treatment of suspected meningitis or encephalitis. When considering the diagnosis and treatment of emergency department headache patients, especially in the setting of this current COVID-19 pandemic, the following can be concluded. Emergency department headache patients who present with potential life threats can be identified. In order to do so, a systematic evaluation is critical, and the electronic medical record can help with this process. Most importantly, subarachnoid hemorrhage can be excluded in patients who present with sudden severe headache, given our current diagnostic capabilities. Also to be noted, head and neck infection, CNS infection, and CNS thrombosis must be considered if subarachnoid hemorrhage is excluded as the likely etiology for patients with potentially life-threatening headaches in the emergency department. During the time of this current COVID-19 pandemic, it is possible that common primary etiologies of headache, such as muscle tension headache, migraine, or even headache related to dehydration, can commonly be seen in emergency department patients. However, when considering patients with potentially life-threatening headache in the emergency department, at this time it is worthwhile to always consider COVID-19 as a potential etiology of these life-threatening headaches. During the time of this COVID-19 pandemic, besides specifically testing for the COVID-19 virus, there's no need to specifically alter our approach to diagnosing and treating patients in the emergency department with life-threatening headaches. If you have any specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you also to go to the fern.org website for more content related to this educational program, as well as other content related to the care of patients who present to the emergency department with life-threatening illness and injury related to neurological emergencies. Thank you.